Okay, so basically today we are going to be discussing the anemia of pregnancy. So basically the most important specific thing that differentiates it from any other anemia in non-pregnant patients is how we are going to manage it. Okay, so we are going to look at the trimester and the week. So if there is mild to moderate anemia, I will explain later what is mild and moderate, but let's just see the treatment algorithm. If there is mild to moderate anemia, up to 28 weeks, then we go for oral iron therapy. And if it is mild to moderate anemia from 28 to 36 weeks, then we go for parenteral iron therapy. Okay. Now, then we're going to see that if that anemia occurs after 36 weeks, then we are going to go for blood transfusion because we do not have time to wait for iron stores to increase by iron supplementation or parenteral. We're going to give direct blood. And if it is before 36 weeks but severe, remember we were talking about mild to moderate before, but if it is before 36 weeks then severe, or if before 36 weeks all the other treatments fail, the oral and parenteral, or if there is excessive hemorrhage at any stage, and if the patient is near term, and if the hemoglobin is less than 6 gram per deciliter or placenta previa, the same things na, antepartum hemorrhage and severe anemia near term. So in all of these cases, in all of these 7 cases, we are going to give blood transfusion. Okay, so this is the basic algorithm which we just discussed, that if the anemia is before 28 weeks, from 28 to 36 weeks, or if it is after 36 weeks, okay, or if it is, and in this case if it is mild to moderate, I'm talking mild to moderate, this is how we classify it. Then before 28 weeks we are going to give oral therapy, from 28 to 36 weeks we are going to give parenteral therapy, and from more than 36 weeks we are going to transfuse the patient. But also if it is this transfer transfusion, we have 6 other points. If it is less than 36 weeks but severe, okay, and if it is less than 36 weeks and other treatments have failed, okay, and if it is, let's say that the patient has had any sort of antepartum hemorrhage at any point, the hemoglobin is less than 6 gram per deciliter, which is the same as being severe, almost very severe or severe, and if the patient is has approached term, can start labor at any time, or if there's placenta previa, which is the same as having a placenta, as having an antepartum hemorrhage. Okay, so this is how we this is a basic approach towards anemia. Okay, the basic approach that we're going to have. So now let's talk about the oral iron therapy. When are we going to give oral iron therapy? If it is mild to moderate, up to 28 weeks. Okay, so always give this with orange juice or vitamin C or meals. The 3 things that you're going to ask the patient to take with iron therapy, and do not take it with milk or tea. You have to counsel the patient about it. So we have done this point. Now, ferrous sulfate and ferrous fumarate, these are the options that we have. Now, basically the thing is that the recommended dose of iron is double. Okay, basically of the prophylactic dose. We'll see that later. Now, what affects the efficacy? As I have already discussed, that taking it with meals, taking it with orange juice, and taking it with vitamin C is of course going to increase its absorption and hence efficacy, and taking it with milk and tea is going to decrease its absorption and hence efficacy. So basically, poor compliance. Many patients are poor compliance because they forget to take the tablets, and Also, if they take them on time, people have, certain side effects. They have nausea, vomiting, constipation, abdominal cramps, diarrhea, dark stools. So they get scared that what is happening, because they're already pregnant, so they're very careful with everything. So they stop taking it. But you have to tell them this, all these effects to a slight extent are normal. Okay, you have to bear them if you want to increase your iron level. And also, do not take it with inhibitors that include things like milk and tea, and also with cereals and wheat products, tea and toast. Okay, so basically these are the two main things. Now, how do you have to counsel the patient? You have to tell the patient that ensure regular intake of iron and with meals, and avoid intake of inhibitors with the iron tablets. And if there is intolerance like nausea, vomiting, diarrhea, and abdominal cramps, then either reduce the dose, do not stop it, or switch the preparation. Maybe if you are giving her fumarate, ferrous fumarate, and she is having intolerance, then start with ferrous sulfate instead, but do not cessate the drug. Okay, now we are going to talk about parenteral iron. Okay, so now basically we are going to talk about parenteral iron, and what was the duration? It was given for mild to moderate anemia after 28 weeks, from 20 to 36 weeks. Now, so it is given in women of less than 28 weeks gestation, in whom the initial treatment has failed. Of course, this is the ideal one duration for giving. But if before 28 weeks oral has failed, then we're going to shift to parenteral iron, and if this fails, we're going to shift to blood transfusion. This is not something to memorize. This is obvious. Okay, one treatment fails, we're going to switch to the other one. And mild to moderate anemia between 28 to 36 weeks, as I've already discussed. Now, what is the benefit? That in this case, compliance is not a problem. Okay, the female does not have to take any tablets, so there's no chance of her for getting it. So this formula is very important, that how much iron is needed. It equals the normal hemoglobin, okay, minus the patient's hemoglobin, multiplied by the weight of the patient, multiplied by 2.21, and we are going to add 1000 in it. Okay, so it's going to be like this, that the normal hemoglobin, okay, minus the patient's hemoglobin, okay, and then we are going to multiply it with the weight. Let's say that the patient is pregnant, so currently she is at let's say 85 kgs, okay, with the weight of the patient, and multiply it with 2.21 and add 1000 in it. Okay, okay, so now what is the next point? IM dose is more popular. Okay, why? Because it has lesser side effects. Okay, now, oral iron should always be stopped before giving this iron sorbitol, because otherwise there are going to be toxic reactions like headache, nausea, vomiting if given simultaneously with oral iron. Of course, we have to stop this. Now, what is the dose? We did not discuss oral dose. Okay, we have to discuss it yet. So let's just discuss the dose for parenteral first. 50 milligram initially. You are going to give a test dose whether the patient is reacting or not, and then or iron sorbitol citrate, and then 100 milligram daily. Okay, initially 50 milligram test dose and 100 milligram daily, or on alternate days by deep IM injection with thick needle on outer quadrant of the buttock, gluteal maximus, using a Z technique. Okay, are going to give the injection like this, and when you give the injection like this prevents dark staining of the skin, dark staining, not staining, staining of the skin. If you do not give it like this, then there will be dark staining of the skin. Okay, this technique is very important. Now, what is the disadvantage? Of course, the point where you give it, there's going to be pain, skin discoloration, and abscess, and reaction in the form of nausea, vomiting, headache, fever, lymphadenopathy, allergic reaction, and anaphylaxis. All the things which happen whenever you give an injection, of course. So these are not specific. Pain occurs, skin discoloration occurs, abscess occurs, reaction occurs whenever you give an injection. But there's also, but there is no extra risk of malignancy or something. Okay, this is just not important. Now, this was the IM route. Now, what was the benefit of the IM route? It had lesser side effects. That is why it was more popular. Now, and we also discussed the dose. There's 50 milligram test dose, and then 100 milligram daily or on alternate days. So IV dose, basically over here we have iron sorbitol. Okay, iron sorbitol for IM. Okay, we have iron sorbitol. So now in case of IV, we have iron dextran. Okay, this is interferon. This is known as interferon. But this dextran has been withdrawn because this had a lot of side effects, so we don't use it. Instead, we prefer iron sucrose. Okay, so just forget about dextran. Just remember sucrose. This is what We use an IV for IV administration, and we give it for 5 to 10 millimeter aliquots up to 3 times per week. Okay, 3 times per week in 5 to 10 milliliter. Okay, so where were we? We had already discussed the topic of oral iron therapy. Now we were talking about parenteral iron therapy, right? And so for parenteral, I said that dextran is no longer used because of its side effects. So what do we go for? Oh, we talked about IM and IV. Let's mix it up. And IM, what did we use? For IM, we gave iron sorbitol. Okay, 100 milligram per day after 50 milligram test dose. Okay, now this was basically more popular, more preferred one because it had lesser side effects. Now in case of IV, we had the options of iron dextran and iron sucrose, but we no longer give dextran, we give iron sucrose. Dextran has been withdrawn from the market because of excessive side effects. Now this iron sucrose complex is known as venofer. Okay, and how much is it given? We do not give it as an infusion. It has not been licensed for infusion yet, so we give in 5 to 10 milliliter aliquots and 3 times per week. Okay, now over here, anaphylactic reaction can occur, but it is rare, and minor allergic reaction can occur in people who already have atopy such as asthma. Okay, so this is it. So we have discussed the oral therapy and the parenteral therapy. So now, when are you going to call the patient again for follow up? You're going to call the patient after 21 days almost, or you can say 2 to 3 weeks, after preferably 3 weeks, because this is when the rise in hemoglobin occurs. Okay. Now the question is, what is the first response that occurs? And that is within almost 10 days, 7 to 10 days, what happens is that increased reticulocytes moderate reticulocytosis has occurred. Okay, so reticulocytes increase first. But the CBC that we do is after 3 weeks. Okay, this is just a theoretical point. And increase in hemoglobin in pregnancy is not more than zero point 0.8 gram per deciliter, no matter how much supplementation. So 0.8 gram per deciliter is the rise in pregnancy per week. Overall, of course, it will raise, but per week it is almost 0.8 gram per deciliter. This is the maximum rate of increase. Now, next point was transfusion. So transfusion, I already discussed that if it is mild to moderate anemia after 36 weeks, or if it is a treatment failure or severe anemia before 36 weeks, or any sort of antepartum hemorrhage, etc. So what are the options that we have? At term, we also give this. So basically the options are packed red cells, and also we have exchange transfusion option. Now why don't we give whole blood transfusion? Because if whole blood transfusion is associated with more reactions, and that can lead to preterm labor and overloading of heart, labor and effects on heart, so we don't give whole blood. This is what we go for. So now we are going to discuss exchange transfusion. In exchange transfusion, what we do is, basically, it is done in very severe anemia. I am just about to discuss the classification. In very severe anemia, and 1300 milliliter of packed cells are transfused, and almost 1500 milliliter is basically blood is taken out by venous section. This is it. Now basically our concern is the classification of anemia, and this was the treatment. Why did I discuss treatment before? Because it's very different now. In OBS, the treatment is very different. Classification is also different. So how are we going to classify anemia? Basically, what we say is that this is the types, and this is a general definition, that if it is less than 11 gram per deciliter, In first trimester, we label it as anemia, or less than 10 gram per deciliter. In second trimester, we label, because gradually there is hemodilution, right? Hemodilution occurs, and plasma volume is increasing. So fall in hemoglobin is normal, but the threshold is to be kept in mind to define anemia. So usually people say that it is, students say that it is less than 11 gram per deciliter. No, it is less than 11 gram per deciliter for first trimester, but for second trimester you're going to label it as anemia when it is less than 10 gram per deciliter, and for third trimester you are going to label it as anemia for a female who presents in third trimester when it is less than 10.5 gram per deciliter. I don't know why is it like this, 10 to 10.5, this is how the definitions are. Okay, so now the classification: mild, moderate, severe, and very severe. When it is from 10.9 to 10, it is mild. This is with respect to first trimester, no, mainly. And when it is 10 to 7, this is moderate. So, okay, so we start from 4, 4, 7, 7 to 10, 10 to 10.9. Almost, let's just take it as 11. Okay, so less than 4 is very severe, 7 is severe, and 7 to 10 is moderate, and more than and 10 to 11 almost is mild. So when it is very severe or severe, we always go for what, we go for transfusion mainly. And if it is mild to moderate, in the before 28 weeks we go for oral iron therapy, and from 20 to 36 weeks we go for parenteral iron therapy. Okay, and what is the problem that the female is going to face? There are a lot of things that can occur. High output cardiac failure can occur, and hemorrhage can occur, postpartum hemorrhage severe, and infection, this is a bacteria, and preeclampsia can occur, and maternal mortality can occur. Fetal effects include fetal growth restriction and preterm labor. So in fetus there is going to be preterm labor and fetal growth restriction if it is very severe. Now basically what is the basically this increase in iron demand. Now we're going to like have a look at the normal value, that 1000 milligram. This is the increased iron demand by 1000 milligram. Okay, extra iron is needed. I just discussed the dose, but the thing is that what are the possible, types of anemia? We are discussing iron deficiency anemia, but there can also be folic acid deficiency anemia, B12 deficiency anemia, and hemoglobinopathies can occur, including thalassemia and sickle cell disease. And sickle cell disease can occur, and what else can occur? Aplastic anemia can occur, and all. But mainly is the iron deficiency anemia and folic and B12, like dietary deficiency occur. Now, what are the causes of iron deficiency anemia in pregnancy? They're the same as we have already studied in non-pregnant people. What are the causes in non-pregnant people? Dietary habits and defective absorption. They have some worm infestation, or they have some, giardiasis or some intestinal problem. And then if there is increased loss, from why does increased loss occur? When there is same again any worm or any ulcer or any, let's say, malaria or hemorrhoids. But in pregnant female it can also be because of any antepartum hemorrhage. Okay, okay, now how are you going to investigate the patient? The first thing is hemoglobin and peripheral blood smear and red cell indices. These are basically ferritin, and TIBC is definitely going to be increased. TIBC is going to increase, and ferritin is the gold standard, like it's the first thing that is affected. It is going to be decreased. Transferrin saturation is going to be decreased, and serum transferrin receptor not usually assessed, but its concentration is going to be increased. Okay, they are same as pre-pregnant values, pre-pregnant changes that we have, non-pregnant changes. And free erythrocyte protoporphyrin is also increased. I'm not discussing this in detail because this is the usual pathology. I discussed the treatment in detail because that was very different for pregnancy. Okay, if you have ever studied iron deficiency anemia, you can you already know everything else. But for pregnancy the treatment was different and the classification was just different, so I discussed that in detail. Okay, now bone marrow examination is not usually done, as we know, until we are suspecting aplastic anemia or kala azar. Okay, kala azar or aplastic anemia. And if after 4 weeks, after 1 month of therapy, there is no response, then we go for this. Now other investigations: stool examination, malaria parasite, and urine examination, because urinary tract infection, renal problem can lead to decreased erythropoiesis, because of decreased erythropoietin synthesis. Now Now we are going to talk about its prophylaxis, which is very important. Just 2 to 3 values, nothing else. So let me just write it down over here. So prophylaxis is very easy prevention. So in pre-pregnant era and in pregnant era, this is how we're going to classify. And in pregnant era, we are going to classify her based on her iron stores, whether they are normal. Just a second. Whether they are normal or they are depleted. Okay, this is the basic classification. So in pre-pregnant era, how are we going to prevent it? We are going to give her 60 milligram per day of iron supplementation for 4 months. Okay, 4 months. Just remember this. It's very easy. 60 milligram per day for 4 months. You can memorize at least this much. And then in pregnant state, we are going to give her, if her iron stores are normal, this same 60 milligram, and if they are depleted, we are going to give her like double of 60, 120 until 240 milligram. Like this is the lowest to highest range. For how much time per day, of course, but for how much time we're going to give it, these are same, this is the different value. For 6 months. In pre-pregnant era, we gave iron for 4 months, and in pregnant era, we give iron for 6 months. And during pregnancy and postpartum, in postpartum period, we continue it for 3 months. Very simple. Okay. And this is basically the iron supplementation that we need to do to prevent it. And other things that need to be treated are if she has any, just if she has any worm infestation, you have to give her albendazole. Deworming needs to be done 400 milligram once. And if she has any other issues, for example, her blood is being lost due to hemorrhoids, then do surgery and dietary advice. This is it. Okay. So now we are going to quickly discuss megaloplastic anemia and just the values, because otherwise it is similar to the non-obstructed topic. So basically, usually in pregnancy, it is mainly due to folic acid. Okay, always remember as compared to B12, because B12 stores are high, we know usually. And what is the requirement in pregnancy? 800 microgram per day. So remember that mostly to folic acid. And what is the requirement of folic acid in pregnancy? 800 microgram per day. And what is the requirement of B12 in pregnancy? 3 microgram per day. So 800 microgram per day and 3 microgram per day, these are the requirements in pregnancy. Okay. Now, what are the causes? We know that dietary deficiency, demand, poor absorption, poor utilization, similar to the causes of iron deficiency, anemia, and all that. Now, what is the investigation? Basically, we're going to do CBC with peripheral smear, and for folic acid deficiency, FIGLU is going to be increase in urine for form immunoglutamic acid, and also plasma red cell flame concentration. And B12 which is associated with pernicious anemia, usually does not occur in pregnancy, because because this causes infertility. Okay, so if someone already has B12 deficiency and pernicious anemia, that person won't even conceive. So we don't find pernicious anemia in pregnancy. Okay, so what are the treatment if there's folic acid deficiency? First, just discuss this first. 5 milligram of folic acid you have to give per day for 4 weeks. And no, you have to give 5 milligram per day throughout the period of disease of the deficiency, and then after delivery you have to give for 4 weeks in postpartum. Okay, so 5 milligram folic acid per day and continue for 4 weeks after delivery. And also check the reticulocyte count on 5th to 8th day. Vitamin C can be used with it. And if parenteral is not usually used, and if you are diagnosing it after 36 weeks, then we don't have time, so we're going to give a blood transfusion. Okay, and for B12, we do not give folic acid alone, otherwise that stealing occurs and neurological symptoms occur. We'll discuss that in another video. And over here we give 3 microgram per day. No, we don't give 3 microgram per day. This is the requirement. I'm really sorry. This is a requirement, and this is met by animal diet. We give parenteral cyanocobalamin 250 microgram IM per month. Okay, this is the dose if B12 deficiency has occurred in pregnancy. 250 microgram IM injection per month. Okay. So, and usually folic acid, the prophylaxis of folic acid deficiency How do we prevent it? In antenatal period, once the female becomes pregnant, she is required to have 800 microgram per day, and during lactation 600 microgram per day. But if she has developed deficiency, we give 5 milligram per day. And for B12, if she has developed deficiency, how much do we give? We don't have to give doses for B12 because it is already met by animal diet, as it was written over here that it is already met by animal diet. So when deficiency occurs, only then we give it 250 microgram IM per month. After delivery, it has not been mentioned in the book that how much do we need to give after delivery, but folic acid after delivery, even if after the female has delivered, we have to give continue the treatment dose for 4 weeks.